Welcome. Thank you for joining us. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General. Today's program is part of our Disability Education Series, a special collaboration between the Blum Center and Mass General Council on Disability Awareness. Before I get started, I just want to go a few items with you all. Please note that ASL interpretation and live captioning are provided today. This session is being recorded for educational purposes. If you're interested in viewing the recording, it'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Please note that you're in listen-only mode. Everyone has muted so we can hear our guest speakers today. If you have any questions for our guest speakers, you may use the chat feature, which is located at the bottom of your screen. We'll have time from the end. Only Blum Center staff, our co-hosts, and guest speakers will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we'd like to ask you to help us complete. Your feedback is important to us as we plan future programs. Okay, so next I would like to introduce you all today's guest speakers. Joining us today, we have Doctors Asha Meloottu and Samira Mortazavi. They are low vision optometrists with the Mass Eye and Ear Vision Rehabilitation Service. Dr. Meloottu went to the University of Washington. She attended the New England College of Optometry, where she developed an interest in vision rehab and binocular vision dysfunction. She went on to do a residency in low vision and traumatic brain injury rehabilitation within the VA Boston healthcare system. Dr. Mortazavi went to the University of Houston as a public health major in optometry school at the New England College of Optometry in Boston. She did an ocular disease residency at the Central Texas VA system in Waco, Temple, and Austin, Texas, with a supplemental emphasis on low vision. She has a special interest in binocular conditions and contrast sensitivity. In recognition of World Braille Day, which is tomorrow, they join us to give a talk on vision loss. But before we turn it over to them, Zara Imir-Hosseini, our Disability Program Manager at Mass General, has a few words to share.
Thank you so much, Amy. On behalf of the MGH Disability Awareness Council, I would like to thank you all for attending. And I'm looking forward to learning about tools and resources available to our patients and employees for blind or low vision. I think this presentation is very timely, as Amy said earlier, as we recognize and celebrate the World Braille Day, which is on January 4th. And it really celebrates Louis Braille's birthday, who was born in 1809 and became blind as a result of an accident. And he quickly mastered a new way of living. And he, at the age of 15, he created a reading and writing system, which we now call Braille. World Braille Day is a reminder of the importance of accessibility and independence for people who are blind and low vision. Advancement in accessible digital document, including improved screen reader compatibility, enhanced navigation features, and increased support for alternative text and document structure. All public-facing documents available on the internet must be accessible to everyone. Supplying accessible digital equipment, document to everyone, including educational and training materials, documentation, and any employment application online. So without further ado, I would like to welcome Dr. Mortazavi and Dr. Meloottu.
Thank you so much. Let me figure out how to share my screen here, and then we'll get started. could start this from the beginning. All right, is everyone able to see it just fine? Great. All right, thank you so much, Sari and Amy. Yeah, will speak for Dr. Mortazavi and say that both her and I are really excited to get to speak with you all about vision loss and something that we're both very passionate about. As we start, we'll quickly go through an overview of what we plan on speaking with you all about. We'll start by discussing what is low vision, the causes of low vision loss, what does vision loss look like, legal blindness and what that means, the prevalence of visual impairments, and then the impact of vision loss. And we'll then go into what low vision rehabilitation looks like and what resources are available to low vision patients, both at Mass Eye and Ear and within the community in the state of Massachusetts, at least. As we start, I wanted to park first on this one slide to highlight how important our vision is. As we look at this picture alone, we have, for those of us that are sighted and are able to see this picture without any difficulty, we get a lot of information about this picture. First, from the color of the picture that looks a little bit cooler than gray sky, we have an idea of maybe the temperature. The fact that this person is on the grass standing up, we can assume that they might have to navigate some lumps and bumps within the grass that they can determine based on their own sight. Vision is such a dominant part of our senses. So much of what we take in our day-to-day is based off of our vision. You think about your morning, just this morning. And similarly, you know vaguely what time of day it is, depending on how much light is pouring through your window, where to place your feet when you step out of bed, and how to navigate to the bathroom. It's easy or challenging depending on how messy or clean your house is, right? If we're thinking of how we develop as children, a lot of what we know to have made of our visual world is based on our vision. We learn colors, we learn letters, we learn how to read based on things that we can take in visually. So when something gets in the way of how we see, it starts to affect our visual function and how we interact with the environment around us. Now, I often hear people say things like, okay, if I take my glasses off, I'm legally blind. The reality is, though, if you put those glasses back on, for most people, you are then able to see pretty well. This does not count as vision loss. What true visual impairment means, it's a form of irreparable vision loss that despite glasses or contact lenses, medications or surgeries remains uncorrectable. Low vision is used synonymously with partial sight, visual impairment, or subnormal vision, all to mean the same thing, that there is some amount of vision that cannot be regained through these sources alone. There are several causes for low vision. Most commonly, some eye conditions such as macular degeneration, diabetic retinopathy, and glaucoma. Physical damage to the eye as well through like a branch to the eye, some sort of ocular trauma can cause vision loss. Damage to the brain from either impact or stroke can cause damage to how things are processed visually by the brain. So you can get visual field loss or have difficulty teaming your eyes together, which then cause binocular vision disorders. There are a whole host of genetic conditions, including retinitis pigmentosa, Stargardt's disease, albinism, that can all impact your vision. And developmental challenges as well in infancy and childhood that impact how the brain and the eyes develop together. One example of this can be prematurity, and some sort of damage to how the eyes develop can cause vision loss irreparably. If we're looking at all of these examples, they all are very different. And this shows up in our visually impaired patients in very different ways. So I wanted to talk about what low vision looks like for each individual, because it varies quite a bit. Before we go into that, I wanted to give you a very parsed down example of the visual system. So this is a very simple schematic to show you the visual system, where light first enters the eye through the cornea here, then through the lens. That light is received by the photoreceptors within the retina, and then that information travels through the optic nerve and is interpreted then by the brain. Now, damage to any part of this visual process can result in low vision. So someone who had a corneal dystrophy or a cataract that prevented light to come to the retina can have impaired vision. Damage to the retina or photoreceptors themselves, similarly, can cause low vision. The macula, I'll highlight, is part of the retina, but it's the area that's responsible for your central vision. And often when there's damage here, it'll look a particular way, which we'll talk about in a moment. Damage to the optic nerve that sends the signal to the brain, similarly. Damage to what's interpreted by the brain. This is what happens with glaucoma. So there is a damage to the optic nerve there, and then damage to the brain itself can cause how the visual world is interpreted. There are certain parts of the brain that interpret your left side of your visual world and your right side of your visual world separately. So damage to the right or left brain can cause subsequent visual field damage. So I wanted to give this example first of a normal visual scene. Say you are babysitting your nephew and niece, and you're looking straight at them. This is what a normal picture would look like. For those of us that are very nearsighted and you take your glasses off or you take your contacts out, they're fairly evenly blurry. You have a blurry scene in front of you. You put those glasses and contacts back on and you have a clear image again. But for those with cataracts, you get a similarly uniform blur of a scene in front of you, which can be hard to navigate. With diabetic retinopathy, what ends up happening is damage to the blood vessels that line your retina can cause bleeds and fluid leakage, which results in damage to the retina and these blind spots that can occur. So when you're looking at the visual scene, you're not quite able to see the faces in front of you. Contrast is kind of changed as well. With macular degeneration, as I mentioned before, it changes your central vision. And so when you're looking directly at an object, whether it's someone's face or you're trying to look at letters to read, wherever you're pointing your eyes is where you have some distortions or a blind spot. So as you're looking at these children's faces, you're not able to see them there. With glaucoma, what ends up being damaged is your peripheral vision. And this can happen to varied degrees, but in something that looks like end-stage glaucoma, it would look similar to this, where you're looking at these two children and you're able to see their faces pretty well, but in the periphery of this visual scene, things are blurry or completely blocked out. With brain damage, you can get field loss, like I mentioned before, that looks similarly here, where you're looking at the children's faces, and 1/2 of that visual scene is entirely blocked out. This would look like damage to the left side of the brain, where the right field is entirely missing. Now, as we're looking at all of these scenes together, they all look very different from one another, and they're all also considered low vision. Someone who has glaucoma, you could imagine, then has very different challenges from someone who has macular degeneration, where your central vision versus your peripheral vision is impaired. So in age-related macular degeneration, what I had mentioned before, you're looking at something directly and having great challenges with where you're spotting images. So often with these patients, reading becomes a challenge. Whereas glaucoma, navigation and navigating through your visual space becomes challenging as your peripheral vision becomes hazier. Now, these can all happen with varied degrees of loss. as well. The point at which it becomes legal blindness is where it's 2200 or less in the better seeing eye, or you have visual field loss of 20 degrees or less in the better seeing eye. And these are definitions that are set out by the Social Security Administration. To determine those two factors, the patient does need to have an eye exam and does need to have a formal measurement of their visual fields. When we're thinking of who this affects, it's good to think first globally, where 2.2 billion people are affected with vision impairment. A lot of these eye conditions that I had mentioned before are easily mitigated by quick, early access to appropriate eye care. The 2.2 billion that the World Health Organization determined factors in people that have refractive error needs and cataracts, two conditions that are very easily mitigated by eye care. So this 2.2 billion isn't an indicator of who globally has low vision specifically. If we're looking within the US, there is about 6 million people with vision loss and 1 million with legal blindness. This number is projected to double by 2050 as we expect our aging population to increase quite a bit. The leading causes of legal blindness and vision loss are macular degeneration, diabetic retinopathy, and glaucoma. And that is the case within the US specifically and varies from country to country. Globally, refractive error and cataracts remain the leading cause of vision impairment, highlighting the need for eye care throughout the world. Similarly, we can see change or prevalence of vision loss looking similarly within the US, where areas that have poorer access to care tend to have higher rates of blindness and vision loss, as indicated by the darker blue regions in this map below. To give us a better idea of our friends and neighbors who have vision loss, who that looks like in our country, I wanted to just read out loud to you some stats set forward by the most recent population studies done by the CDC. So more than 1.6 million Americans who are living with vision loss or blindness are younger than the age of 40. Over 350 people with vision loss or blindness are living in group quarters, such as nursing homes or prisons. 20% of all people older than 85 years old experience permanent vision loss. More females than males will experience permanent vision loss or blindness. There is a bigger risk of vision loss among Hispanic or Latino individuals and Black individuals than white individuals. The prevalence of vision loss, like I mentioned before, varies state by state, ranging from 1.3% in Maine to 3.6% in West Virginia. And kind of calling back to what we had discussed before, because so much of how we function in our world is dependent on our vision, it can have quite a bit of an impact on an individual who has been sighted for majority of their life and then has all of this vision loss as a result of a genetic condition or a disease. And some of this could be within the pediatric population, delayed motor or language skills, some barriers to education, lower rates of employment. You can have the sense of social isolation as you have a loss of independence. There can be quite a few changes in family dynamics as now the person with some visual impairment has the need to rely on other people. You can have difficulty with mobility and a higher risk of falls and fractures. And this population tends to have higher rates of depression and anxiety, a decline in cognition as activity tends to decline as well. And you can have these things called Charles Bonnet hallucinations, which are the brain and the visual centers in the brain trying to fire and remember these images to kickstart the vision to work. And so these patients will often look out into their living room and see flowers springing out from the ground or faces coming out of nowhere and think that they're going crazy, where really it's their brain trying to stimulate seeing again. And so in order to mitigate a lot of things, we have the benefit of vision rehab services, the things that myself, and Dr. Mortazavi do. And so to talk more about that, I'll pass it over to her.
Thank you, Dr. Meloottu. So a patient has vision impairment and they are referred to us for a vision rehabilitation examination. And so what happens during this examination? Generally, we will take a detailed history. We will get your visual acuity, or measure how well you can see or how well the patient can see. We will test eye muscle movements, how well the eyes work together, how sensitive the patient is to contrast. We will get an updated glasses prescription, and then we end the exam with our recommendations and demonstrations of various low vision aids. And so these examinations are pretty long. They can last between an hour to an hour and a half. And so we start off with a very, very detailed history. So we always start off with, tell me a little bit about yourself. We want to know what you do on a day-to-day basis. We want to know, do you live in a one-story house? Do you live in a three-story house? Your daily living skills. Do you read magazines or novels, or were you never an avid reader? Do you have issues with spot reading, which means reading the ingredients on a can or reading your prescriptions? Illumination preferences, meaning do you want your house to be as bright as possible? Do you turn on all the lights at the same time? Or are you someone who prefers to have a very, very dim lit house? Glare is also a big issue with our vision impaired patients. Sometimes, even though they do prefer lots of light, they do have a little bit of that washout effect with the glare. Mobility is asked to make sure patients are not hurting themselves and they're safe with their vision impairment. So sometimes patients will say that they're tripping a little bit more often than they used to, and or they're not as confident with going up and down stairs in their home. Driving is a little bit of a sensitive topic. So often we'll ask, are you still driving? Do you feel comfortable driving? We do have patients with vision impairment who are still legally allowed to drive, and that's great. We try to make it as safe as possible, but still that is a discussion that we have. Distance spotting has a lot to do with if you're in a crowded area, are you able to spot your loved one in a crowd? Do you get lost in a restaurant or a grocery store? The impact of vision loss on independence is a very big topic as well, especially with our older generation who they've been independent their entire lives. They were the breadwinner, and then they end up needing more help than they're used to. Visual goals are something that we discuss. We often, the first exam, patients don't really come in with a visual goal. They just want to know what's available. And then as the years go on and we continue to see you regularly, goals will get more and more specific. So they can be as specific as there's a program that I go to and I sit in the back of the class and I want to be able to see the board. And then we're able to tailor the exam to that. We always discuss current aids. So did you go and buy an over-the-counter magnifier? Does it work well? Does it not work well? And then of course, ocular history. A patient's examination is tailored to their ocular history. There is a good amount of research that we do before an examination. We go through all of the notes to kind of see what the timeline was and what is beneficial to test during the exam. So like I mentioned, each examination is very unique. It is based on your ocular disease or condition, or even your lifestyle, your age. Are you at a working age? Do you still go to school? And that's what we tailor it based off. On the left, there is a picture of a reading acuity chart. And we use that rather than a traditional chart that just has letters. The reason we do so, and it's actually in different languages, I don't know if you can see that there, but the reason we do that is because we try to test real life circumstances. So maybe reading letters inside of the exam room is okay, but outside in the real world, you're having issues with reading. And so that's why we want to make sure whatever we test is relevant to your day-to-day life. The picture in the middle is of a Goldman perimeter. We have one at Mount Sinai. We're very lucky to have one. And what this does is it allows us to manually map out your peripheral vision and to see if there are any blind spots that maybe you haven't noticed yourself. This helps us with making recommendations based on driving and also with occupational therapy as well. So if there's some blind spots that maybe haven't been noticed before, we can talk about it and make you more aware of these spots. The picture to the right is of a trial frame. And so during a low vision examination or a vision rehab exam, we use these frames in order to give you a really good refraction or basically prescribe you glasses. The reason why we use a trial frame is because it allows for the patient to freely move their head. And so in the real world, you may have, let's say, a blind spot, and you need to look past that blind spot by moving your head. In a traditional phoropter, like I have behind me, it's not easy to do, and it's a little bit too bulky. So you will get a very thorough refraction and an examination. So now let's fast forward past an hour with us, and now we have finished the low vision exam. It's time to discuss recommendations. So for tools, we have probably around 100 or so tools that we can use, but it comes down to high ads, which are stronger reading glasses, magnifiers in different modalities, telescopes that can be held or attached to glasses, CCTVs, which are a larger format of a digital magnifier, head-mounted devices, which can include VR or virtual reality devices, OCR, which is optical character recognition. This is wonderful for our stroke patients who have some level of agnosia or with severe vision loss, for people who need a little bit more of an auditory aid than a visual one. Tints or light filters that can help with glare and contrast. Glasses, of course, like I discussed, smartphone applications, and then we have non-optical aids such as audiobooks, talking watches, and basically everyday items that are just easier to use for visually impaired patients. So I want to go over a few of the tools I discussed in a little bit more detail. Starting off with prisms. So a prism is a lens that allows for light to be bent to manipulate how the patient views an image. And so a prism is very useful for peripheral vision loss and binocular issues, or conditions where our eyes are just not working together, causing double vision. And there is a picture of a dog at your bottom right. And there's a picture next to it of a dog that someone with double vision might see. So, and double vision doesn't always mean that two dogs are next to each other. Sometimes it's a blur that cannot be fixed with just normal glasses. And so prisms can look like the image to the left where it is stuck onto the glasses to your habitual frame as a temporary measure, or they can be ground in so that no one knows you have prisms in these glasses, but it's helping with your everyday vision. In vision rehab, we do use these temporary measures for stroke patients who are seeing double, even though their double vision may progressively get better. We do want them to be comfortable while they're going through this. And so here are some wearable devices. On the left, I have a picture of some light filters. These filters are great for glare and contrast sensitivity. There's also scientific evidence of some filters like the FL41 filter that is great for migraine management. So we do have quite a few patients who come in with photophobia or light sensitivity from migraines. We have the Iris Vision, which is a wearable device that magnifies surroundings for the user to see more clearly. And it is kind of like a VR headset. At the bottom, we have a patient who is wearing a bioptic. A bioptic is a useful device for patients who otherwise would not meet legal requirements to drive. So as you can see here, this patient is wearing a monocular bioptic telescope, which it's a wonderful tool, but of course, the Massachusetts RMV does have many laws surrounding this and many requirements. So we're very grateful that we can use it, but of course, there are some limitations. And I have placed a video of a digital magnifier. We use these a lot in our clinic. And I have a video here because it's very hard to describe what it does. So can you hear the sound?
Does anyone hear the sound?
I can't hear it either.
No? Okay.
Okay, so let me kind of go through what's going on. So this patient right here, he is wanting to read this magazine and needs a little bit of magnification. So a digital magnifier has many levels of magnification, which is wonderful because a handheld magnifier or traditional magnifier does not. Here you can see the patient is enhancing contrast because many times our world is not high contrast and not everything is black and white. So these will help, these settings will help increase contrast. And then here, it's just showing that you can do writing, and I have patients who will do crafts under a digital magnifier. And so it's just a really great tool that we offer. And yeah. We're going to, I have one more video. So in the examination, we often ask the patient if they would like us to adjust the settings to their phone to make it more accessible. But then we also will download free applications that are offered. And so this application that we see here is called Seeing AI. It is a OCR application or optical character recognition application, and it has lots of wonderful settings. So here you can see the patient is just taking a picture of a document and it will read out the document for you. It'll also have an option where it has short text, so you don't even have to click on the phone. You would just show the camera any sort of text and it would read it out loud for you. And going next, so this is called product, and all the patient would do is scan the barcode of whatever product they are looking at, and it'll read out what the product is. And so,
Yeah, my apologies for the sound, because as this is happening, you'll scan the barcode and you'll hear the app saying things out loud. You just can't hear it on your end.
yeah, so it's, but I recommend everyone downloading it just to see how it is. It's called Seeing AI. It's on the Apple Store, App Store. And if you have an Android, it's called Envision, Envision. Here it is talking about a scene. So you would take a picture of a scene and it would tell you what is going on around you. This is wonderful for our stroke patients who have agnosia, and so they can describe what they're seeing. And here is a currency identifier. American money is not very visually impaired, I guess, friendly. So, but in a minute, it'll show Canadian money, which is a little bit easier for our visually impaired patients. And yeah, those are really kind of the main uses of applications on smartphones. All right, and so not all low vision tools have to be optical or eye related. On this slide, we have a picture of large font playing cards, a liquid indicator, which is a great tool for patients who often complain that they will over pour coffee or water in a glass. And then on the right side, we have a talking watch. And so at the very top, I put a website of
I'll try to share it now. Give me 1 second.
Of course, yeah. So this website is one of the websites that we will recommend to patients to go through on their own, because there are so many adaptive devices on here. There are excessive devices, as you can see, that's a talking tape measure. And then as you go down, there are lots of like there's a sewing aid, recreational devices, and basically most things that you're having issues with on a day-to-day basis, they will have some sort of adaptive product that you can purchase. And then, okay, so Mass Pioneer resources. Mass Pioneer so our resources include vision rehabilitation with doctors like Dr. Meloottu and I, and there are 2 more doctors who work in our service. A referral can be placed by your eye care provider or virtually any physician, but we do require an updated eye examination to ensure that your ocular health is monitored. It's very important to make sure that not only are we on our end, we're taking care of your vision, we do want to make sure that you're taking the appropriate eye drops if you need to, or everything is going as it should anatomically. We also have an on-staff psychiatrist for adjustment to vision loss. Our provider is Dr. Ethan Lester, and I will talk a little bit about him in a future slide. So I just put a picture of the front door of our clinic. We are on the 8th floor of of Mass Pioneer. We are kind of away from the hustle and bustle of the clinics downstairs, which is wonderful. But I don't know if you can see through the window. We have a couple of CCTVs right at the front, and then our clinics are in the back. And so here is Dr. Lester. He gives psychosocial adjustment counseling services. He will do an initial evaluation in about 6 to 8 sessions. If additional services are needed, he will refer them accordingly. Session topics include emotional distress and crisis management, mindfulness, acceptance, and behavior modification, illness narrative and simulated illness disclosures, and behavioral medicine techniques. With goal setting with functional limitations, and of course, practical support. And this includes just keeping an open dialogue with the other vision rehab providers. Lots of times, Dr. Lester will send me an email and say, you know, after seeing this patient for 5 or 6 times, they had a question regarding a device that we had discussed. And so it's really nice to kind of keep an open dialogue between us. Now, I talked about what Mass Pioneer offers, but we are very, very lucky in Massachusetts. We have so many resources for our visually impaired patients. So community resources include government-funded Massachusetts Commission for the Blind. MCB is available for patients who meet legal blindness requirements. However, if they do not, we can still utilize other organizations such as MABB, which is the Massachusetts Association for the Blind and Visually Impaired. We also have Lions Club, and then centers like the Carroll Center for the Blind and Perkins School for the Blind. Massachusetts is a mandatory reporting state that requires eye care providers to report if a patient is legally blind. So once the reporting has been done, MCB will send a certification of blindness and connect a patient with a caseworker or a social worker to help acquire services as needed. These caseworkers are wonderful because they will contact the patient's low vision provider, and we will give the recommendations that we noticed during the exam. And then many times they're able to, free of charge, give these devices or whatever recommendation to the patient. It's a tremendous financial relief for visually impaired patients, and we're very lucky to have that. So skipping over to the Carroll Center, this is a small excerpt that I copied from their website, but it's a beautiful campus in Newton, Massachusetts. It is for adults with vision impairment, and it has rehabilitation, technology services, employment training and support, low vision services, O&M or orientation and mobility services, and recreation. They have lots and lots of fun group activities as well. Personally, I have done fencing with some visually impaired patients, so they really do have everything. Excuse me. So Perkins School for the Blind is for our pediatric population. It was founded in 1829 and was the first school for visually impaired children in the United States. And some notable alumni include Anne Sullivan, who, as we know, was Helen Keller's teacher, and then Helen Keller as well. And if you're someone like me, I highly recommend reading their website. They have a really rich history of advancements in vision impairment, and they are wonderful. They,
Yeah, and we highlight all of these things as examples for tools and resources, kind of similarly to what Zari said, thinking of Louis Braille, right? There comes a point with vision where you have to adapt something new to adjust to this new part of your life, which can be really challenging. But there are so many resources available with tools and other resources within the community that we love to be able to offer our patients who often come to us not knowing what's available to them. And to talk through a few examples of this, we're going to give some examples of patients that we've been able to help with these resources and low vision tools. So I had a patient a few months back who has something called Beatty's corneoretinal dystrophy, where you get these tiny flecks within the cornea and the retina, and vision overall is slowly gets impaired. It's a genetic condition, and for her, she's in her young 30s. She was seeing pretty well for majority of her life. One eye became really poor. The other eye was what she was relying on. That eye saw maybe 20/40, which is not bad. And then pretty soon, within the course of a year, that eye also started to decline to where both eyes are similarly around 21/50. For those of you that don't have glasses or aren't sure what that means, it's generally very, very blurry. It'd be very hard to see things very far away, and within probably an arm's length as well. She came to me now with a lot of concerns over this newfound vision loss. She had difficulty seeing her computer screen at work and signing off on documents. She was really smart and really on top of work and her eye condition, but didn't know what to do. Like, will she need to find a new job? How is she going to navigate this as well? With this condition, because it's genetic, the expected course is that it continues to progress and progress until about until you hit legal blindness, usually in the 5th or 6th decade of life. And she had 3 young kids that she was worried about how to take care of, as she expects that this continues to grow worse. Now, she is an exception among a lot of patients who was someone who's really proactive in looking for resources. And something that I didn't mention among this list, as is that she found a Zoom support group, a national Zoom support group to address her genetic condition specifically. So she was getting a lot of emotional support through this group. But what we had discussed was classes through the Carroll Center to help her continue with some activities that she felt like she needed to give up. I believe she sailed quite frequently in Carroll Center, has a blind sailing group, and she also knitted, and they also have a knitting group as well. We got her referred to the Mass Association for the Blind and Visually Impaired for occupational therapy resources as she's trying to navigate her workspace and how to navigate her computer now that she has a difficult time seeing smaller texts. She was previously seeing Dr. Lester, but we reestablished her with him, given the newfound vision loss and the difficulty with adapting to the change. We always start with glasses and high reading power, something very basic and easy, along with the magnifiers as well for spotting needs around the house. And we discussed software that she can install onto her computer screen to blow up images that oftentimes employers will help to install, knowing that there is some visual impairment. We talked about those apps as before, and we demonstrated some electronic magnifiers as well. And I think the thing that at least I was, proud to have walked away from with this patient was that she came in with not very much hope as to her eye condition and her visual impairments, and left feeling like, okay, we have a lot of options. They'll just be different from how I was normally able to navigate with my vision.
All right, and I'll end the presentation with our second patient. She was a middle-aged female with advanced age-related macular degeneration, or AMD. Her challenge was that poor central vision caused her to have a loss of interest in her hobbies due to vision impairment. And her main concern was that she just felt like she had lost independence. She used to be someone who was active, was always doing some sort of craft. She was an avid scrapbooker, and she made jewelry. And she felt as if her children and her spouse had to always entertain her. And so what I recommended was classes through the Carroll Center, because the Carroll Center, like mentioned before, has virtually everything. A digital magnifier with an elevated base. And so this is kind of something newer that we did. We placed a very large digital magnifier on a base so that the patient can place her hands under this base and see her hands as she does crafts. And so she exclaimed that, wow, this is the first time I've seen my hands in years. So that was very nice. We did establish with Dr. Lester, and that is because we did want to address the fact that she was upset about losing her independence. We did single vision reading glasses, and that was just to help her see the magnifier a little bit better. We talked about magnification apps, and this was because even though the digital magnifier is wonderful, it was a little bit bulky because of the size that she wanted. And so we wanted something that was a little bit more portable. And lastly, we discussed the importance of light. And so because she had a little bit of issue with glare, we suggested a neck light that goes around her neck, and then it offers light that doesn't go in her eyes, but just straight on what she's looking at. And so in conclusion, technological advancements and assessments for people with low vision or vision impairment have become much more available, and the effects of vision loss can be minimized by implementing these accommodations in a person's life, and a new standard can be established. So vision loss is not an end, but a beginning to a new way of seeing and a different way of living. And we're inspired by the holiday that we have tomorrow with National Braille Day. And thank you, and let us know what questions you have.
Thank you so much. We're now at the end of the session. If you have any questions, feel free to enter them in the chat. We have a question regarding insurance coverage. In general, does insurance cover for vision rehab appointments?
Yeah, I can answer that.
Yeah.
Yes, there are quite a few insurance companies that do cover. There's, I want to say maybe one or two that does not, but when you call or when you are referred to vision rehab, our medical assistants are very good at making sure you have coverage. And if you do not, we can always refer you to a clinic that does take your insurance.
Sometimes for the exam portion itself, there may or may not be any insurance coverage. Certainly for the devices, it's a little harder to get insurance companies overall to cover the devices that we often recommend. Sometimes we can make allowances for that with Mass Health, that it requires a lot of prior authorizations to be written. Which is why we then also have other resources such as Mass Commission for the Blind, MABV, that are able to get you devices a little bit more easily than through your insurance.
Thank you. These are all wonderful resources that you listed. Would we be able to get a list of these so that we can list them on our accessibility sites?
Yeah, we're happy to do so. I think some of the like MABV sites as well do have a whole list, but we can send something out.
Thank you. We have a participant who was just diagnosed with mild retinitis pigmentosa. This person's still driving, working, not sure if they need an entire rehab visit, but is interested in glasses. Do you have a recommendation for what color tint would be best? And can they see someone for the glasses?
I'll let Dr. Mortazavi also share too, but with some of these conditions, it's really smart to establish patients quickly with vision rehab. Now, it's different if this patient had macular degeneration and things were kind of stable, but with retinitis pigmentosa, which is a genetic condition, we expect that there is going to be some amount of progressive loss that results in legal blindness, possibly. So getting someone with this kind of condition established sooner than later makes adapting to changes with their vision easier to overcome.
Yeah, if you come in for a vision rehab exam, we also do a glasses assessment. So what's nice about here is that we have a lot more time with the patient, and so we have time to make sure that the glasses are perfect. Well, not perfect, but close to perfect for you. As for tints, there are over 35 tints that we can go through. We do narrow it down by disease, but it's better for us to assess it. But in general, tints that we look at are going to be like a yellow or orange based or like a rose colored. But we do need to do an assessment because it's very subjective to what tint would provide the best or the most visual relief.
Thank you. And to be seen by you, what should the referrals say and who should they send it to?
So the referral, all it really needs to say is that there's a recommendation for a vision rehab assessment. And if any provider sends it, that would work. We just do want at least an updated eye exam within the last year or so, because we're happy to do a comprehensive exam as well, but it would have to be, I guess, on a different day when we do comprehensive exams, not during your low vision assessment.
Something that is always nice to include in the referral is a functional need. If the patient can identify, hey, like I'm having a hard time seeing my computer, and if we know that ahead of time, that's always great. Sometimes we get referrals with patients that are monocular, have like NLP and seeing 20/20 in the other eye. And we're happy to see them, but oftentimes these patients are functioning just fine because their better seeing eye is what's going to be carrying them through.
Thank you. We do have a question about the recording of today's session. It will be made available on the Blum Center website at massgeneral.org/Blum-Center. I'll also enter that link in the chat in a moment. We have a question regarding screen time. Do you have any recommendations as far as how much time one should spend looking at screens?
We have a rule. It's called the 20-20-20 rule. I'm sure some have heard about it, but basically it stands for every 20 minutes, look 20 feet away for 20 seconds. Basically what it's saying is that every half an hour or so, just give your eyes a break by looking far away. Our eyes have the most stress on them when we're looking at near objects. So a computer, a book, anything up close gives our eyes a little bit of tension and stress. And so if we look far away, like out a window or like 20 feet away, that will give our eyes a little bit of relief.
Thank you. And I think we have time for one final question. Are there universal accommodations that can reduce barriers in healthcare for those who are blind or with low vision?
Can you repeat that question?
Are there universal
There's probably, yeah.
Sorry. Are there universal accommodations that can reduce barriers in healthcare for those who are blind or with low vision?
Mhm.
I am sorry, I'm gonna say one thing and then
Okay.
I'll let you talk really. I think one big thing would be print size and the ability to have like some sort of OCR, optical character recognition. I want to say the biggest by far complaint that we get is I can't read my prescription bottles, or for instance, if I am printing out like a prescription, they'll say I can't even read what this says. So I think the option of having larger print on almost everything, like even prescription bottles. I know there are different, like they're in the VA, for instance, they have a program where you can have prescription bottles read to them using a device, but I'm not sure this is accessible to everyone or they're not aware of it.
Yeah, I think that's really good. I think it's a harder question to answer because low vision looks very differently. And so the accommodations that would need to be made also look different. But the easiest thing is, I agree, large print and increasing brightness. I think if I don't think this fits under an accommodation, but increased access to just primary eye care. A lot of these conditions are, easily mitigated by being followed by a primary care optometrist or having their diabetes well controlled. And that, would prevent a lot of these things from growing to low vision at the rate that they would otherwise.
Thank you. Before we end today's session, do you have any final thoughts you'd like to share with the audience?
Yeah, of course. I just want whoever has a loved one who's going through vision loss, or if you're going through vision loss, we just touched like the tip of the iceberg with all of the programs and recommendations and accessibility options that we have available. And Dr. Meloottu and I know even if there's something that we have never encountered, we have so many resources where we will reach out to different companies. And if there's a lens that we even have to design and create for you, we're happy to do so. So, don't ever feel like your vision is too bad, for instance, to get care.
Yeah, or too good, right? There's no need too big or small. We're happy to see anyone with any amount of vision loss. I think that was also very well said, Dr. Mortazavi. We're just happy to get to share some of what we do and what we're passionate about with you all today.
Thank you so much, Dr. Meloottu, Dr. Mortazavi, for spending the hour with us. Special thank you to our interpreters and live captioner for your assistance today, as well as Zari for making this session possible. As I had mentioned, today's program is being recorded. If you're interested in the recording, it'll be made available on the Blum Center website at the massgeneral.org/Blum-Center. While we work on making these resources available on our accessibility sites, if you're interested in the list of the resources shared today, feel free to email the Blum Center at pflc@partners.org, and I'd be happy to share that with you. All right, everyone. Thank you so much.
Thank you.
Have the rest of the day.